Good morning. My name is Nancy Dunn-Thompson, and we're at the Elizabeth McGowan Training Institute this morning and filming for mmlearn.org. This is part of our Ask the Geriatrician series, and we want to start by thanking the Baptist Health Foundation of San Antonio for their generous support, which has made this filming and our other videos in Ask the Geriatrician possible. We also want to thank the Methodist Healthcare Ministries Foundation, the San Antonio Area Foundation, the Prior Trust, and the many other organizations and individuals who have supported the mission of mmlearn. Now, we want this to be interactive, and we have such a special guest with us today. We want you to be sure and send in your questions. And you can do that in two ways. If you're joining us on the internet and you look at the top of the screen, you're going to see the Ask bubble. It reminds me of a comic bubble. If you click on that, you'll be able to send an email to us, and we'll give that to Dr. Raji, who will respond. If you are listening by phone or for some reason cannot send an email, you may also phone in your question to area code 210-264-7000. Dr. Raji is the professor and director of internal medicine and geriatrics at the UTMB Medical Center in Galveston. He's also the program director for the Geriatric Fellowship, and he's with the Department of Internal Medicine and the Division of Geriatric Medicine. I also understand that he's a very kind and gentle geriatrician, which I found all of them so far to be. So we're very lucky to have him here, and please send in your questions, because not often will we have someone with such a tremendous background to respond to our questions about transfer trauma. Thank you very much, and Dr. Raji, welcome to mmlearn.org.
Thank you. Thank you for such a great introduction. My name is Mukaila Raji, and today we are going to be talking about transfer trauma and how we can reduce constant trip to the ER, because emergency room is not a safe place for seniors. I'm going to start this talk by talking about some of the consequences of frequent emergency room visits and re-hospitalizations. The number one consequence is increased exposure to infections, especially flu, Clostridium difficile diarrhea, methicillin-resistant Staphylococcus aureus, bed bugs, lice, and visit to emergency room and hospital recurrently can also increase the risk for bed sores, falls and fractures, high risk of drug toxicity, delirium, especially in patients living with dementia. Then there are complications from procedures that you get when you go to hospital recurrently, from bladder catheter, intravenous administration. Recurrent hospital visit is not cheap. In 2004, it cost Medicare $17.4 billion. It creates stress to patients, family, and nursing home. And this does not even include the common occurrence of loss of property, including dentures, glasses, hearing aids, wallets, canes, and so on and so forth. Now, if we are going to reduce recurrent hospital visits by senior citizens, we need to answer two questions. How common are recurrent emergency room visits? What are the most common medical diagnoses accounting for recurrent admission in the elderly patients? Published research in the New England Journal of Medicine shows that 20% of Medicare patients discharged from the hospital will get readmitted within 30 days, and 34% of them in 90 days. The common top medical diagnosis for readmission as listed in this slide: congestive heart failure, pneumonia, chronic obstructive pulmonary disease, psychosis, gastrointestinal problems, and especially medication poisoning. It is important to know the content of this slide because this will begin to guide us in developing and implementing programs to reduce recurrent hospital transfer in the elderly population. Now, I will say a few things about medication use that lead to emergency department visits. The reason this is important is because this is potentially preventable. A study in the Annal of Internal Medicine, 2007, showed that among seniors with multiple emergency room visits to U.S. hospitals, 3 medications account for 1/3 of these visits. What are these medicines? Warfarin, which is used to prevent stroke in people with atrial fibrillation, insulin, which is used for diabetes, and digoxin, which is used for heart failure and to control cardiac arrhythmia. By knowing this, we can begin to look at how we can develop programs to prevent drug toxicity related to these 3 drugs. Specifically, among the nursing home residents, the commonest diagnosis for acute hospitalizations and emergency room visits are urinary tract infection, pneumonia, and congestive heart failure exacerbation. Acute hospitalization and ER visits in nursing home residents in various studies has been shown to be reduced when patients and their families inform the nursing home staff about their preference for do not resuscitate orders. We also do know that weekend and evening night shift in nursing home is associated with increased likelihood of hospitalization for urinary tract infection. This information begins to guide us how we can design systems to reduce recurrent emergency room visits. Now, it's important to recognize barriers and challenges to treating acutely ill residents in the nursing home. By recognizing these barriers, again, we can begin to design systems to remove them. Difficulty in obtaining antibiotics quickly. Poor documentation of resident wishes for hospitalization. Insufficient staffing, and especially high prevalence of dementia in the nursing home. Some of these lead to defensive practices by doctors and nurses which erode the autonomy of the practitioners and can potentially compromise patient quality of care. The other challenges we have in nursing homes are limited access to biotechnology and immediate testing to allow us and to guide us in choosing the right treatment. Equally important is the unusual presentation of illnesses in the elderly population of nursing home. Then there are family, ethical, legal, and regulatory concerns which make it complex and complicated for physicians and nurse practitioners to practice evidence-based medicine in nursing home. Many people would choose different treatment because of these concerns. Again, this can reduce the autonomy of the clinicians to choose the evidence-based medicine. So, having shown you the severity of this condition of recurrent hospitalization and some of the challenges that we face, I will now show you evidence from published research of what we can do to reduce frequent emergency room visits and hospitalizations in the older population. I will show you evidence of new models of care to improve care transitions. I'm going to emphasize the role of mid-level clinicians, specifically the nurse practitioners and the physician assistants. I'm going to show you how we can empower our patients, families, and caregivers. And I will describe system change in the nursing home, in the hospitals, and the emergency room. And by doing so, we'll be able to come out with ways to remove the barriers to care in long-term settings. I will start this by showing you a study published in the Journal of Advanced Nursing. In this practice model of nurse practitioners, they had 2 full-time nurse practitioners who provided primary care to about 2,900 nursing home residents in about 22 nursing homes. This program, over 1 year, was shown to prevent hospital admission by approximately 40%, to improve the confidence and job satisfaction of the nursing home staff. It saved money. It led to development of new skills in the long-term care workforce. And it can lead to enhanced quality of care. If you cannot see some of the slides that I'm showing you, these slides will be available for you to download by clicking on the link. Another practice model that has been published is collaborative care between the nurse case manager and community health worker, which has been shown to reduce recurrent hospitalizations. This model of care used evidence-based clinical guidelines with feedback to primary care providers such as physicians, nurse practitioners, or physician assistants. And the major emphasis of this approach is patient self-management education, including home-based assessment and education, as well as self-management for specific situations, addressing depression, socioeconomic challenges, and caregiver concerns, especially for patients living with dementia. The other model of care that was recently published in the Telemedicine Journal of Health shows that telemedicine care through videoconferencing reduces recurrent emergency room visits. This telemedicine care is comparable to hospital referral for face-to-face medicine. It's faster with respect to diagnosis, health examination, treatment, and it also leads to improvement in the quality of life of retired persons who might require medical attention without traveling. The good thing about teleconsultation is that it can be managed and done by not only medical doctors, but by physician assistants and nurse practitioners. Now, since we do know the most common diagnosis for recurrent hospital and recurrent ER visits, there are systems designed to reduce recurrent admission for specific medical diagnosis. And in this slide, I'm showing you a program that was summarized in the recent Cochrane database system review that shows that patients living with congestive heart failure, structured telephone support and telemonitoring reduces risk of all-cause mortality congestive heart failure-related hospitalization. It improves the quality of life of these patients. It leads to cost reduction, and it increases evidence-based prescribing by the clinicians. This is what we do at the University of Texas Medical Branch to reduce congestive heart failure readmissions to our acute care for the elders unit. This system incorporates nurses, social workers, physicians, as well as medical and physician assistant students who call patients on days 3 and 7 to ask specific questions, and if they detect any problems or challenges, to help the patient develop solutions to overcome them. For example, they call the patient to ask, do you have a follow-up appointment with your doctor or nurse this week? Do you weigh yourself daily? Do you have your diuretics? And then they get a series of instructions on when to call their doctors if they develop signs and symptoms of worsening heart failure. For example, a gain of 2 pounds weight within 24 hours. What can we do to reduce ER transfer from nursing homes? Because on any given day, there are more patients, there are more residents in nursing homes than you have in acute care hospitals. So it is important to look at what we can do to reduce nursing home transfer to ER unnecessarily. From review of literature, it is very important that we create systems to remove barriers and challenges to treating acutely ill residents in the nursing home. We need to develop systems to obtain antibiotics quickly to treat the common sources of infection in nursing home: urinary tract infection, pneumonia, and skin infections. We need to develop systems to improve and transmit documentation of resident wishes for hospitalization and instruction for CPR. We need to be flexible in the nursing home with respect to staffing for peak hours and weekends. This is not easy, but we need to use the information from research to design a system to reduce this recurrent admission. It is key to invest in some biotechnology and point-of-care testing. Electronic medical records will help in prevent some of the drug toxicity-related hospital transfers. Again, if you cannot see the slides, you can download them by clicking on the link in your computer. It is very important, which is one of the reasons we are giving this talk today, to create a program of continuous staff training to improve recognition of the unusual presentation of illnesses in the elderly. It is important for nursing homes, in particular, to form a strong, active, and functional family council comprising the patients, the family members, nursing home staff, and some representatives from the community. They will inform us of some of the challenges and how we can overcome them. Time and time again, and from my reading of the literature, having a nurse practitioner full-time or a physician assistant has been shown to be cost-effective, to improve quality of care for nursing home residents, and to reduce recurrent hospital transfer of these patients. We also need to develop systems to specifically target and case manage the top causes of emergency room visit from nursing home. The top conditions are listed in this slide: congestive heart failure, COPD, delirium and psychosis, pneumonia and complicated urinary tract infection, complications related to PEG tube insertions. By developing systems to recognize these conditions and by implementing interventions very early, we can prevent or reduce some of these conditions from developing into full emergency room transfer. And I would like to spend a few minutes on the issue of feeding tube complications. Use of feeding tubes in patients with advanced dementia has been shown in many studies. Recent study from the Journal of American Medical Associations and a recent review from Cochrane database has shown that use of feeding tubes in patients with end-stage dementia does not improve survival, does not prevent aspiration pneumonia, does not heal or prevent bed sore, does not improve functional status. And yet, 1/3 of nursing home residents with advanced dementia have a feeding tube inserted. The question is, how does this happen? Where do they get this feeding tube? What we know from a recent study from the Journal of American Medical Directors Association is that 2/3 of people with advanced dementia have their feeding tube inserted during an acute care hospitalization, usually for pneumonia, dehydration, or difficulty with swallowing, dysphagia. So if we are going to be looking into how we can reduce unnecessary feeding tube use, we need to start looking at where patients end up getting these feeding tubes. We also know that when we talk to patients in the early stage of dementia or patients with no dementia, most nursing home residents stated that they would rather die than live in a state of dementia with a feeding tube. This is published in the Journal of General Internal Medicine. Then what happens after nursing home residents with advanced dementia receive feeding tube? 64% died in less than 12 months after tube insertion. About 20% will require a tube replacement or repositioning within 4 months. And these usually involve transfer to the hospital. And many of these patients, over the next 12 months before death, many of them will spend 9 days in hospital for issues and complications related to feeding tubes. Simply stated, having a feeding tube in a patient with advanced dementia only decreases the quality of life and leads to more complications. So how do we approach this in terms of reduction of unnecessary tube feeding? We do know that from studies that was published in JAMA this year, that only 6%, approximately 6% of hospitalized nursing home residents with advanced dementia had an order to forego artificial hydration and nutrition. Now, the potential solutions, there may be other solutions. They start with education of everybody, caregivers, families, patients, about what feeding tubes can do and what feeding tubes cannot do, the pros and cons, the negative impact on quality of life. And it is also important to obtain written advance directives in everybody in nursing home or assisted living about their preferences with regard to whether or not they want to be resuscitated when they have terminal illnesses, others to forego artificial hydration and nutrition, or whether or not they want to be hospitalized when terminally sick. We also know from another recent study published in the Journal of American Geriatric Society that we need to do a better job of transmitting advanced directives to different facilities during patient care transactions. We need to improve communication of medication lists. We need to develop a more robust and effective system for medication reconciliation of nursing home patients when they return back from the hospital. Specifically in this study by LaMantia and colleagues, we need to develop systems such as patient transfer sheets for nursing home patient transfer to emergency departments, use of prospective order form or documents for life-sustaining treatment and patient preference. We also need to have protocols for early recognition and prompt treatment of the top conditions that we do know lead to patient transfer from their homes or from nursing home or assisted living to ER. For instance, pneumonia. Many patients ended up going back to the hospital because they do not complete the antibiotics. It is important for all patients to get their pneumonia and flu vaccination. It's even more important for the nursing home staff, doctors, nurses, and everybody there to also get their flu vaccination. Studies have shown that when nursing home staff get vaccinated, it leads to a reduction in flu incidence in residents of nursing home. Another protocol that should be developed is for chronic obstructive pulmonary disease and asthma exacerbations, to teach our patients to recognize early signs of flare-up, such as change in sputum color and quantity, or subjective increase in cough and shortness of breath. On some occasions, for patients living alone, it might be prudent to have the patient have a few days of antibiotics and a few days of oral steroids, so that when the patient recognizes early signs of exacerbation of COPD, they can start the treatment on their own and then call their physicians. By so doing, we can at least reduce recurrent hospital visits for COPD exacerbations. Also, congestive heart failure. We need to teach our patients about the importance of monitoring their weight or symptoms of swelling and to comply with medication for congestive heart failure. It has been shown in various studies that when patients with heart failure are sent home from hospital, when they see their doctors or nurses within 7 days, there is a lower risk of being readmitted to the hospital. And with respect for urinary tract infection, it is very important to minimize the use of bladder catheter. I will describe briefly another program that has been shown to reduce recurrent hospital admission. It's called Program of All-Inclusive Care for the Elderly, PACE. It's a comprehensive community-based geriatric care that enrolls frail older adults who meet state criteria for nursing home care. They tend to be eligible for both Medicare and Medicaid. PACE uses interdisciplinary teams to evaluate participants and deliver care in different settings. It's a managed care which receives capitated payment from both Medicare and Medicaid. The goal of PACE program is to optimize health, function, and quality of life through the delivery of effective care and services, primary care, preventive care, restorative care, supportive care, and palliative care. And they do this in particular by avoidance of inappropriate and expensive hospital and nursing home utilization. A more comprehensive description of this program is published by Weiland and colleagues in the Journal of American Geriatric Society. PACE uses daycare attendance, frequent therapy encounters, and personal home care. And it's been shown in a recent studies published in the Journal of Gerontology that the PACE sites that provide more daycare center and more outpatient therapy had lower hospital admissions. And the reason why PACE works is because of enhanced care coordination, which lead to better outcomes, reduce emergency room visits, and it's been shown to be cost effective. I would like to end this talk by laying emphasis on what I consider the most important task for all of us. We should respect our patients. We should empower them by giving them appropriate information so they know what to do. The first thing is we should teach our seniors about what is considered normal aging and what is considered disease. We should also let all senior citizens know about potentially dangerous drug combinations that can lead to emergency room or visit. First, we should know that the symptoms listed on this slide, they are not normal part of aging. So if any senior citizen has any of these symptoms, you should see your medical doctors or your physician assistants or your nurse practitioner. In particular, the items that I highlighted in red should trigger a visit to your doctor because they could be a leading indicator of more serious problems. Depression, unintentional weight loss, incontinence, always waking up tired. No matter how many hours you sleep a night, always waking up tired may be a leading indicator of serious sleep apnea or serious cardiovascular conditions. Memory problem, to the extent that it affects your life, such as forgetting your spouse's name or leaving your wallet in the freezer. These are some of the symptoms. These are not normal part of aging, and if you do have any of these, it's important to talk to your doctor or your nurses or your physician assistant. It's also important for all seniors to know about potentially dangerous drug-drug combination that can send you to the hospital. This is a summary of this combination as published in the Archives of Internal Medicine as well as the Journal of American Medical Association. Cotrimoxazole is an antibiotic that is commonly used for bladder infections, skin and lung infections. When combined with glyburide, a medicine for diabetes, it can lead to hypoglycemia and coma. We also know from the following study that cotrimoxazole antibiotics used with Coumadin can lead to severe bleeding, shock, and hospitalization. Another combination that we should all know, whether we are patients, caregivers, or clinicians, is that combining cotrimoxazole with angiotensin inhibitors, which are used for hypertension and heart failure, such as enalapril, lisinopril, can lead to high blood potassium and cardiac arrhythmia. These are some of the studies published, and if anybody is interested in this, the references are listed in this slide. We should always also empower our seniors to always prepare for their visits to the clinics so that they should always have their doctor as well as their pharmacist. Do I still need this medication? And ask your doctor if you are correctly taking Coumadin, digoxin, or insulin. We do know from published studies that these three drugs account for 33% of all emergency room visits for drug poisoning. These are very important drugs. They save lives, but if it's used improperly, they can lead to more problems. Seniors should also ask their doctors and nurses and physician assistants, is this medication that I'm taking interacting with other medications I'm using? The next question also is, can my illness that I'm experiencing now, or my symptom that I'm experiencing, be worsened by these medications? Thank you very much, and I will take your question. The first question is, how much training are medical students receiving about this topic? Unfortunately, the systems of care, training system of care, is not a major part of medical student training. And right now, the emphasis at UTMB, what we do at UTMB, is to have different courses that teach medical students as well as residents about how we can improve care transitions between patients going from nursing home to hospital and from hospital to nursing home. But definitely there is more to be done to improve education and training of not just medical students, but nursing students as well as internal medicine and other residents on how we can improve communications and care transitions between different facilities. One system that has been very helpful is the widespread adoption of electronic medical record system, which has allowed communication between different pharmacists and hospitals, and in some cases, some nursing homes. The next question is, should my pharmacist tell me about my drugs and what are dangerous for me? This question is from Diane. That's a very good question. We underuse our pharmacists. In fact, the training of our pharmacists is so extensive that they have more information on medication than physicians. So I always encourage my patient that when they go to see their pharmacy, they should talk to them. They are always very enthusiastic about talking to patients. They can tell you about drug-drug interaction that are dangerous, and they can always even call your doctors to let him or her know whether you should be on this medicine. So yes, please, you should always talk to your pharmacist. They are very helpful. The other question is, how can I get more information about what is abnormal aspect of aging, which is disease, and what is normal aging? I will direct the person who has this question to go to the National Institute of Aging website. There are links, which is nia.gov or National Institute of Health.gov, nih.gov. And there is also the website of American Geriatric Society. If you put American Geriatric Society on the search engine, you will have a lot of information about what is considered disease and what is considered normal aging. This question is from Louise. Do hospitals offer information to help nursing home residents after they are discharged from the hospital? I will have to say that the level of communication between hospitals and nursing home is not good enough. There is a lot of breakdown in transmission of post-discharge orders from hospital to nursing home, as well as pre-admission orders from nursing home to hospital. So what we do at UTMB is we do have electronic medical records where we print out patient instructions that are given to the person who is taking the patient back to the nursing home. We are fortunate because some of the nursing homes around us that we send patients to, UTMB faculty also happen to practice there and hold medical directorship. So there is a continuity of care that allows us to improve transition of patients back and forth from nursing home to hospital and hospital to nursing home. So yes, I agree with you that every hospital should develop a system to improve communication of information between facilities. This question is, what do I do if I get mail order medications and no pharmacist is available? What I will recommend is to talk to your doctor or your nurse practitioners. The good thing about most mail orders or insurance companies, they do have toll-free lines that you can call to ask questions. And many of the mail order medication service do have case management program to help patients comply with their medicine, especially for the top common diagnoses, such as congestive heart failure, hypertension, asthma, COPD. Yes, please, you need to contact the pharmacy service. The next question is from Pamela. What exactly is a hospitalist? Hospitalists are a group of doctors who only see patients who are admitted to hospitals. 90 to 100% of their patients are patient admitted. They usually do 7 days on. They do 12-hour shift for 7 days and have 7 days off. They don't have any, don't see patients in the clinics. Studies have shown that having hospitalists can actually improve transition of care because they see patients with all these problems and they get better at it. Next question is, can my mother refuse to go to the emergency room from the nursing home? Yes. The Patient Self-Care Determination Act allows a competent patient who is capable of good decision to decide the amount and place of care he or she wants. Now, it is important to talk to the physician, nurses, and ask them why they want to take your mom to nursing home. But the quick answer to this question is yes, you can refuse. However, though, many patients with dementia, especially in nursing homes have up to 70% prevalence of dementia. So a patient with dementia might actually need to be admitted. And if the patient is refusing, it might be because of some of the confusion and psychotic complications. So one has to look at the context of the decision to send the patient to the emergency room. Again, some of the slides here will also be available on demand at the end of the talk. This question is, a feeding tube seems essential to life. How can I learn more? Now, this is a very good question. There are situations where feeding tubes are important and they save lives. If somebody has a stroke and we expect recovery from the stroke and the person cannot swallow, and the person has a long enough life expectancy, it's okay to put a feeding tube with the expectation that after recovery, the feeding tube can be taken out. There are also some conditions, especially in younger adults, whereby there is serious problem with swallowing, that a feeding tube might improve nutrition. The specific scenario that I have spoken about in this talk is the use of feeding tube in elderly patients with advanced dementia. In this set of patients, studies upon studies in reputable journals have shown that feeding tubes do not prolong life in elderly patients with advanced dementia. 64% of them will die in less than 12 months. And within those 12 months, there will be recurrent hospital admissions to fix the feeding tube because it's clogged. So this is about providing information for family and letting families and patients making a decision based on information. This is not to say one decision is bad or good. It's about letting people have the information and making rational decisions based on that. You can learn more about this again by going to the American Geriatric Society website. They have information for patients and families on the pros and cons of feeding tube use in senior citizens. What do you do when hospital recommends PEG tube on the patient? If you refuse, what are the other patient's other options? When hospital recommend PEG tube on your patient, again, any procedure, before you do any procedure in patient, the patient and their families need to be informed about this information I gave in terms of, would this feeding tube lead to better quality of life? Will it lead to improvement in my survival? Is it going to change the underlying condition? If somebody has metastatic lung cancer with advanced dementia and you put a feeding tube, is it going to improve their longevity, or is it going to just prolong the dying process and add more misery? The important thing is, if a patient with late-stage dementia refuses feeding tubes, then the other option would be what they call comfort feeding, or modification of food in such a way that the patient can eat whatever he or she likes and let nature take its course. That is why dementia patients underuse palliative care and hospice care. And many patients with dementia end up in the intensive care unit at the last days of their life. This is about family knowing what we can do with technology and what we cannot do to prevent doing more harms to the patients than good. Well, I want to thank you, and I want to thank everybody for their time, and I look forward to the next talk on polypharmacy. Thank you.
Thank you, Dr. Raji. Thank you for joining us on the internet, and thank you for joining us on the phone. We want to know what you think. When you tell us what you think, we know how to improve what we're doing. So please look at your computer screen and click on Survey. It's only going to take you about 5 minutes, probably less than that, to complete the survey, and we'll add it to the data that we're collecting this year, and it will influence the programming that we do next year. If you are a guardian and you're joining us, do not complete the survey on the screen. You will receive, for your CEUs, an email with a link to a survey that you need to complete. This was really interesting for me. I was really taken by the opportunity to empower family councils by giving them this information and getting them more involved in the decision-making process and helping all family members be more informed and more patients informed as they make some of these critical decisions. And I also was reminded of how many other videos that we have that might help you at the end of this if you watch them. I think you might want to watch by Carrie Allen, Help My Mother Is on Drugs. It's about all the medications and the considerations that you should make when you have an older family member who's taking medication. Another one is Delirium by Dr. Michael Lichtenstein. Another one is on the Physiology of Aging by Dr. Parks. It's a great one. And then we have 2 videos by Dr. Klugman that are on advanced care planning, excellent to watch related to this topic. He also has a web link through the University of Texas Health Science Center in San Antonio that will link you to all the forms that you need in the state of Texas related to advanced care planning. We also want to let you know that you can get copies of the slide presentation by clicking on the attachment on the screen. They will also be available on demand. We're very happy with having Dr. Raji here, and we're very excited that he'll be joining us in about 15 minutes. So we'll see you live in 15 minutes. And don't forget, today is the first day of fall. It's National Fall Prevention Day, and watch some of our videos on fall preventions because falls are the #1 cause of accidental injury and death in older adults. Thank you, and we'll see you in 15 minutes.